My name is Alexander Zarbock. I'm an anesthesiologist by training. I'm located in Münster in Germany, and I will talk about biomarkers to prevent acute kidney injury. Here you see my outline. First of all, I will introduce the subclinical AKI concept. Then I will talk about stress and damage biomarkers in the next. Then I will talk about who should get a biomarker assessment. And in the last part, I will talk about how to use biomarkers to prevent acute kidney injury. But first of all, I will start with subclinical AKI. You all know the KDIGO definition. This definition is based on changes of the serum creatinine and or urine output. However, both functional biomarkers have several limitations. The serum creatinine has a low sensitivity because the serum creatinine levels only increase if more than 50% of the GFR is lost, and the urine output has a low specificity because it can be influenced by several factors. Here you see that acute kidney injury is a continuum, starting with an increased susceptibility and ends on the right side with a kidney failure. An increased risk and kidney damage are clinically silent. We cannot use the functional biomarker serum creatinine and urine output to diagnose an increased risk and damage. If we have a disease progression and the GFR goes down, then we can use the serum creatinine and urine output to diagnose and stage an AKI. However, to detect an increased risk and kidney damage, that means the golden hour of AKI, we need new damage or stress biomarkers. And this is highlighted in this landmark study by Michael Haas and colleagues, and they demonstrated that kidney damage without a loss of function impacts patients' outcome. Here they divided 2,000 patients based on the serum creatinine levels and a biomarker level. In this case, they used NGAL. On the two groups on the left side have a normal serum creatinine. The left group has a normal biomarker level, and the right group has an increased biomarker level. And you see that patient with a normal serum creatinine and an increased biomarker level reflecting a kidney damage without a loss of function had a significantly increased dialysis and mortality rate, suggesting that a kidney damage without a loss of function impacts patients' outcome. And based on this landmark study, a new term was introduced, and this is the subclinical AKI. Here in this 2x2 table, you see the relationship between kidney damage on the x-axis and function on the y-axis. Normally, we are in the upper left box, and if there is an injury, we move to the upper right box. So there is a damage without a loss of function. And if we have a disease progression, we move to the lower right box. However, we cannot use all biomarkers to detect the subclinical AKI, as shown in this study by Claudio Ronco, which was published last year. Here they investigated whether the new biomarkers, TIM2 and IGFBP7, these biomarkers are involved in the G1 cell cycle arrest, can be used to detect the subclinical AKI. And they demonstrated that these biomarkers cannot be used to detect a subclinical AKI. In the next part, I will talk about stress and damage biomarkers. When we talk about biomarkers, we have to distinguish between functional biomarkers, for example, creatinine, urine output, cystatin C, and damage biomarkers. And here on the right side, in the upper figure, you see that nowadays we know a lot of biomarkers and they have different locations. And I will focus on NGAL, TIM2, and IGFBP7 because these biomarkers can be measured at the bedside by using point-of-care devices. NGAL is probably still the best evaluated biomarker. This is a study which was published more than 10 years ago. And here the authors investigated whether NGAL can predict an acute kidney injury in pediatric patients undergoing congenital heart surgery. And they demonstrated that the NGAL levels only increase in patients who subsequently develop an acute kidney injury, but not in patients who didn't develop an acute kidney injury. On the right side, you see the area under the curve. This is almost perfect. The area under the curve was 0.98. This study by Claudio Ronco again demonstrated that NGAL can also be used in adults. Here, the authors measured plasma NGAL in patients admitted to the ICU, and they demonstrated that plasma NGAL levels only increased in patients who subsequently developed an acute kidney injury, but not in patients who didn't develop an acute kidney injury. The area under the curve for NGAL was quite good. It was 0.78. But they also wanted to know whether NGAL can be used to predict the need for renal replacement therapy. And here you see that the area under the curve is even better. It's 0.82. They used a cutoff value of 150 nanogram per mil. The sensitivity and specificity for this cutoff value is quite good, but the negative predictive value, as you can see here on the right, is almost perfect. It's 0.99. That means that 99% of the patient with an NGAL value below 150 nanogram per mil didn't require renal replacement therapy. That means that we can use this biomarker to exclude patients. This is a meta-analysis which was published more than 10 years ago. So they included 19 studies, more than 2,538 patients. The primary outcome was prediction of AKI. As you can see here, the specificity and sensitivity was quite good, and the area under the curve is 0.81. However, NGAL has also some limitations. This is a study by Jay Coyner, and they looked whether NGAL can be used in adult patients undergoing cardiac surgery. So they measured NGAL at different time points, and they demonstrated that the area under the curve was 0.72 for stage 1 AKI and 0.88 for stage 3 AKI 6 hours after ICU admission. In the next step, they wanted to look for the performance of NGAL in patient with a normal kidney function and patient with an impaired kidney function. Impaired kidney function was defined as a GFR below 60 mils per minute. And here they demonstrated that the performance of NGAL was significantly better in patients with a normal kidney function compared to patients with a reduced kidney function. In 2013, the two new biomarkers, TIM2 and IGFBP7, which are involved in the cell cycle arrest, were discovered. And in the context of the Sapphire trial, the authors performed a large observational trial and looked whether the two new biomarkers can predict a moderate or severe AKI within 48 hours after ICU admission. And here you see that the performance of TIM2 and IGFBP7 is quite good, and it was significantly better compared to the performance of other biomarkers, for example, NGAL, cystatin C, and so on. They defined two cutoff values. The lower cutoff value is 0.3. Patient with biomarker level below 0.3. Here, the negative predictive value is quite good. It's 0.94. That means that 94% of the patient with a value below 0.3 didn't develop a moderate or severe AKI within the next 12 hours. And the higher cutoff value is above 2.0, and this cutoff value has a very good positive predictive value. This was 0.86. We also investigated these two new biomarkers in cardiac surgery patients. So we measured the biomarkers for 8, 12, and 24 hours after cardiac surgery. And here you see the composite value. So that means we took the highest value within the first 24 hours, and the area under the curve is quite good. It's 0.896. But if you want to measure the biomarker only once, you should measure them 4 hours after cardiac surgery. And here the area under the curve for TIM2 and IGFBP7 is still quite good. It's 0.805, and this was significantly better compared to the area under the curve of NGAL, which was only 0.679. So in this study, the authors investigated whether TIM2 and IGFBP7 levels are influenced by different comorbidities. Here, they demonstrated that TIM2 and IGFBP levels only increase in patients who subsequently developed an acute kidney injury, but the biomarker levels were not influenced by comorbidities, for example, chronic kidney disease or chronic heart failure. However, the biomarkers can also be used to predict adverse long-term outcomes, as you can see here. This is a follow-up of the Sapphire trial. Here, the authors looked for death and dialysis after 300 days, and they demonstrated that patients who had an acute kidney injury and had low biomarker levels initially had a better outcome compared to patients who had an AKI and higher biomarker levels in the beginning. So here you can see when we should use damage and functional biomarkers. Initially, we should use damage biomarkers. With these biomarkers, we can detect the subclinical AKI, and later on, when we have reduced kidney function, we should use the functional biomarker. The question is, who should get a biomarker assessment? Should everybody get a biomarker assessment or only some patient population? And as you know, that's the same with troponin. If you measure troponin I in all your patients, the negative predictive value is quite high, but the positive predictive value is low. But if you measure troponin I only in patients with symptoms, the positive predictive value goes up, and that's the same for AKI biomarkers. So if you measure them in all your patients, the negative predictive value is high, but the positive predictive value is low. And that's the reason why Ming Sharla and Stuart Goldstein came up with the renal angina concept. This concept says that the biomarkers should only be measured in patients with a certain risk profile. This consists of different risk factors and a certain clinical condition. And if the biomarkers are elevated in these high-risk patients, we can start therapy, as you can see here. How should we use the biomarkers to prevent acute kidney injury? As I said, the biomarkers can be used to detect the golden hour of acute kidney injury, and that means an increased risk, stress, and kidney damage. So before the kidney function goes down, and at this stage, preventive measures can be implemented. And it has been shown that the implementation of preventive measures in patients at high risk for acute kidney injury can significantly reduce the occurrence of AKI after cardiac surgery, but also after major abdominal surgery. This has been shown in several trials. So in summary, I can say damage biomarkers can detect the subclinical AKI, which affects clinical outcome. There's a difference between stress and damage biomarkers. Biomarkers can predict the development of an acute kidney injury. However, not everybody should get a biomarker measurement. And biomarker-guided implementation of a bundle can reduce the AKI rate. Thank you very much for your attention.